All right, can everybody see my slides? We're good? Okay.
Yes.
So again, my name is Dr. Siegel-Robles. I'm in the primary care office of Capital Health that's in Princeton. And I'm here today to talk to you about osteoporosis and building stronger bones. I like to start this talk with a picture of my parents who have both passed. I've loved them dearly. My mother suffered from osteoporosis for many years. She was on many medications and treatments for it. She suffered fractures. She had a hip fracture once when she fell. One of my relatives gave her a nice bear hug one time and fractured a rib by doing that. And then actually she fell back one time and fractured her pubic bone. And that was unfortunately the beginning of the end for her and for her in our lives. So it's a topic that's very close to my heart, and I want to talk about it more. I want to, well, I find that a lot of people and even some clinicians feel like osteoporosis is just a part of aging and expected to happen over time and accepted that way. However, we are all here to talk about things, to talk about how it does not have to be that way. And that's what our talk is about today. Okay, so what is osteoporosis? It's a weakening of the bones. It's thought to be some kind of imbalance between the bones that makes the cells that make bones, the osteoblasts, and the cells that help resorb bone for new bone to be made. They're osteoclasts. Osteoporotic or weak bones are easier to fracture. This always shocks me when I see it myself. Women reach peak bone age by the age of 16 to 25, and it goes down slowly from that time. So we want to talk to you about how we can slow that progression down. Okay, here up on the top left, you can see there's pictures of bone. The one on the left is normal bone. You can see nice bone bridges and only small holes between the bridges that make that bone strong. This one here, you can see there's very few bridges and big holes between the bridges. This all makes the bone less strong, and that's what we see in osteoporosis. The picture on the right shows a woman who not only is she losing height, as you can tell, but she's also getting an increase of the curve in her back. See, it goes from normal to kind of very curved. This is something called kyphosis, and it can be seen not infrequently in osteoporosis, and that's what usually gives us the shortened height, because the bones are kind of going from this to this. These bones get scrunched down. It makes the curve more pronounced and makes our height get shorter. And I would like to just point out at this point of the lecture, just so you remember, because for me it's very important, when you go to your physicals each year, and I hope that you all are going to a physical every year, when the staff are taking your vital signs, please make sure that they take your height. Many staff tend to take all the other vital signs like blood pressure and pulse and temperature. But when it comes to height, they say, oh, well, it was this last time, so I'm just going to put it down this time. Ask your staff to please take your height measured so that you can know too if your height is changing and be more conscientious of what's happening. So why is it important for women to know about osteoporosis? Well, 1 out of every 3 women over 50 will have an osteoporotic fracture in their lifetime. That's a pretty astounding number. And for women who are over 45 and have to be hospitalized for osteoporosis, it's oftentimes a longer hospitalization than other things, even like breast cancer or heart disease or diabetes complications. Most often, osteoporosis has no symptoms. So a lot of people say, oh, I have pain here, I have pain there, it must be osteoporosis. It's usually not. That could be arthritis, but osteoporosis is usually without any symptoms until you have a fracture. Spinal or vertebral fractures, like I was showing in the previous picture, those are the most common types of fractures in osteoporosis. They're also known as compression fractures because that bone gets kind of just scrunched down. And that's what causes the loss of height. Other fractures you can get with osteoporosis include fractures of the wrist, shoulder, hips. People, when they're about to fall, they put their hands out, so it's not uncommon at all to break your fall with your arms and then sometimes break your wrist or your arm because of it. Hip fractures are probably the most dangerous fractures of osteoporosis, and we'll talk more about them. So what happens if you don't bother to look for osteoporosis or treat it? Osteoporosis affects 44 million Americans aged 50 or over, men and women, due to fractures, chronic pain, hospitalizations, changes in daily life because of that. Prior fracture, if you've had already an osteoporotic fracture, your chance of having another one is very high. 86% is what the data shows us. So again, it's not just the acute hospitalization for, let's say, a hip fracture. It's management of significant pain. Oftentimes a hip fracture needs to have emergency surgery most of the time to fix it, which also means that that patient might not be in their optimal condition for a surgical procedure, but it's emergent. It can mean the loss of ability for that person to take care of herself and be independent, to get in a car, get in and out of a car and drive. And it's a significant amount of time to recover from the fracture as well. Physical therapy, home health aid, all these things may be needed and add to the difficulties and the cost of osteoporosis. Can men get osteoporosis? Yes, they can. 1 out of every 5 men over 50 will experience an osteoporotic fracture. For men over 50, the risk of getting osteoporotic fracture is actually higher than the risk of getting prostate cancer. Men who have been treated, let's say, for chronic obstructive pulmonary disease, particularly years ago, we used a lot of oral steroids like prednisone. That absolutely accelerates osteoporosis. Some of the medications used for prostate cancer, like the anti-androgens, accelerate osteoporosis, and as do the medications used for breast cancer. They can all accelerate osteoporosis. And getting back to men, by the age of 70, a man's risk of osteoporosis equals that of a woman. So here are some risk factors for osteoporosis. Postmenopausal, because there's not as much estrogen as there was prior, which helps keep bones strong. A thin woman, low body mass index. Caucasian women, Asian women tend to have more osteoporosis. If there's a family history of hip fracture, smokers are more prone to osteoporosis, as are people who drink excessive alcohol. A diet that's poor in calcium and vitamin D. Certain medications, like I alluded to, the corticosteroids like prednisone. Again, this is not the nasal steroids or the inhaled steroids for asthma, because those are minute doses, but this is oral steroids such as prednisone or IV steroids. Dilantin is an anti-seizure medication. And then, as I said, the chemotherapy for breast cancer, many women are on a type of medication called aromatase inhibitors, and they also tend to make bone density decrease over time. Hyperthyroidism, particularly if it is not being controlled. If it's being well controlled, it's less likely to accelerate osteoporosis. And then again, a history of a previous osteoporotic fracture always makes it higher incidence of having a second one or a subsequent one. So there's a test that we use to check for osteoporosis. It's called a Dexa scan or a bone density scan. Who is tested and when? All women 65 or older are recommended to have a screening bone density scan. Now, this is on the recommendations of the American College of Gynecologists and also the United States Preventive Services Task Force. I personally feel that that's a little too late to screen for osteoporosis. I look for all sorts of other good reasons to screen earlier than that. And remember also, women who are postmenopausal, but earlier than expected, are at increased risk for osteoporosis. Remember, the average age for menopause is age 51, but there are a lot of women who go through premature menopause. That could be 40, 45, and that means that their bones have less time with that increased estrogen, so they are more prone to getting osteoporosis earlier. Okay, and again, screening people with the risk factors that I mentioned before. Now, talking about men, I do believe that men should get screened for osteoporosis. The United States Preventive Services Task Force doesn't recommend this for men because there's currently not enough evidence to assess if it's risk-benefit to do so. But I do believe men should get checked, certainly if they have a family history, if their mother had osteoporosis, if they start to notice their height is decreasing. If I notice a kyphotic kind of curve in their upper back, I will also screen them for osteoporosis. Someone who has a fracture, the type of fracture we call it is a fragility fracture, which it means that you fall from a height of either standing or lower, sitting, and you get a fracture from that height. That's called a fragility fracture. That's not uncommon in osteoporosis. And so someone who has a fracture like that should be screened for osteoporosis with a Dexa scan, even if they are not at postmenopausal levels. So understanding how to read that Dexa scan is not so easy. It's a little confusing, and you should ask your doctor to go over the result with you. We look at something called a T-score. So the T-score is comparing your bone mineral density to that of a woman at peak bone age. Remember, from 16 to 25. So the scoring goes -1 or more positive means normal bone. -1 to -2.5 means osteopenia, which means weakened bones, but not quite osteoporotic. And then -2.5 or more negative means osteoporosis. This test is usually recommended to check every 2 years. Sometimes it's checked more often for certain reasons, but usually it's every 2 years. There's another tool that's used. It's called a FRAX, which is like an algorithm to figure out your risk of fractures. It was adopted by the World Health Organization in 2008. It tries to estimate the 10-year probability of either a hip fracture or a major other osteoporotic fracture. And sometimes this screening tool can serve as a guideline to decide, to help you and your doctor decide if treatment is needed. This is probably not that easy to read, but if any of you are interested, you can Google FRAX and find out how this will come up. It's a questionnaire. This is from me, but it was some years ago. And as you can see on the bottom, it measures my risk of having a major osteoporotic fracture in the next 10 years or a hip fracture in the next 10 years. And there are guidelines for deciding whether to use medications based on this. So let's take some time to talk about prevention, because really that's very important in osteoporosis. And these same measures that will help prevent osteoporosis are equally important to do when there is osteoporosis present. Okay, so calcium intake, vitamin D intake, regular exercise, and taking measures to prevent falls. So a lot of the literature shows that calcium seems to be best absorbed, and the best source would be from food rather than from calcium supplements. If you do take a calcium supplement, it should be taken in divided doses. In other words, take a dose in the morning and the other half in the evening, because we can't absorb that much calcium at any given time. And take it with food. It's easier on the stomach that way. For vitamin D supplementation, anywhere from 800 to 1,000 international units, or IU, is what's recommended. If your doctor checks a vitamin D level on your blood tests and finds that you are low in vitamin D, those numbers can be increased. I often use medications, much higher doses of vitamin D than is written above because the levels are still low. Magnesium also tends to help with osteoporosis prevention as well. So here's a list of some foods that are rich in calcium. They tend to be the oily, fleshy fish like sardines and salmon. Also dairy products. Most dairy products have calcium in them. And all your nutrition labels should show you about how much calcium are in these products. And lastly, there are foods and drinks that are fortified with calcium, such as almond milk, orange juice, tofu, that are good because they have calcium put in them. And lastly, for prevention, it's exercise. And for me, this is a very, very important part of our talk today. 3 types of exercise I'm going to mention to you. The most important, the most common we talk about with osteoporosis is weight-bearing exercise, which means simply that you're doing the exercise while carrying around your own body weight, which means such as walking, hiking, dancing, Zumba. Then there's weight resistance, which is done either with weights or resistance bands. This will help build up your muscles and improve balance, as well as agility, very important for preventing falls. And the last type is stretching, such as yoga, Tai Chi, Pilates. While these exercises do not necessarily help strengthen the bones, they do help improve balance, agility, and that's what helps decrease falls. And fall prevention is also very important. You may want to avoid certain exercises, particularly if you haven't been doing them for a while, if you do have osteoporosis or you're at risk for osteoporosis. High impact type exercises, running, jumping, step classes, sometimes some high intensity exercises may be just not great for osteoporosis and may make it easier for you to fall, which is not good. So I would suggest that you talk to your doctor, try to come up with an exercise plan that is good for you and that you will enjoy, because all exercise has to be enjoyable. I'd just like to take a little time to extol the virtues of walking. Walking, for me, I believe is the best exercise out there. Almost anyone can do it. Most people know how to do it. You don't need to use special outfit or clothes. You don't need special equipment. You don't need a gym membership. All these things make walking very accessible and easy to do. This is something I tell my patients all the time. Not only does that walking help prevent and treat osteoporosis, but it also helps blood pressure go down. It helps decrease your cholesterol numbers and levels. It helps decrease your blood sugar. It helps decrease your weight. Walking is an aerobic exercise. It's not only good for your heart, but it's really good for the mind, for decreasing stress, clearing your mind, thinking about nothing, thinking about problems, and even coming up with solutions to problems. All that can happen while you walk. I would suggest to you that you start slowly, particularly if you're not used to walking for any length of time. Take it slow. Walk around your house, inside and outside. Slowly increase, maybe around the block. And give yourself weeks at a time doing the same amount, and then just slowly increase the time that you walk, perhaps the speed with which you walk, perhaps put in an incline here and there. All that will be helpful for you. And who knows, you may become a lifelong walker, which would be great. I would just say, leave one more term for you. Like Nike says, just do it. We can all think of many reasons why we don't feel like exercising. It's too early, it's too late, I'm too tired, it's too hard, it's raining out. Tons of reasons why not to, but there are just as many, if not more, to walk. Okay, so remember what Nike says, just do it. Back to prevention. The last thing about prevention is preventing falls. You want to, just like you would baby proof your house, if you had a child or grandchild in the house, you want to fall proof your house. Anchor down all rugs, perhaps do away with little rugs or carpets if you can. Use good shoes that are supportive. Not a great idea to walk around either barefoot or in socks because it's easy to slip. You want to make sure you have good lighting where you walk. And I would say in particular, a night light, which helps you get from your bedroom to your bathroom is a really good idea. Avoid slippery surfaces. If it's rainy out, if it's cold out, just be very careful, walk slowly and get your base of balance so that you can prevent falling. Don't multitask when you're walking. How many people do we see walking around, phone in hand, looking down? Not only does it cause car accidents, but it causes people to fall. Have your eyes checked on a regular basis, usually every 2 years. Even if you're not having any eye problems, it's recommended to get eyes checked. And see your doctor if you're feeling any kind of symptoms of dizziness or lightheadedness, and let it get checked out. So now we're going to talk about osteoporosis medications that are available for use. The most common type of medication is called a bisphosphonate, and it works by slowing down that bone resorption. Common names that you may or may not recognize: Fosamax is a brand name for alendronate. It's taken once a week. Actonel, risedronate, also once a week or once a month. And Beniva, ibandronate, is a monthly pill. However, they were not able to show a decrease in hip fractures in their data. For all of these bisphosphonates, they need to be taken in a very specific manner. And that is first thing in the morning or on an empty stomach, fasting. You need to stay in an upright position, standing or sitting, but upright. Take a full glass of water and then wait between 30 and 60 minutes before eating. I usually tell my patients to leave the pills and a big glass of water at their bedside on their night table. As soon as they get up and stand up and feel steady on their feet, take that pill, drink the whole glass of water, and then start to get your clothes ready, perhaps take a shower, get your food ready. And usually by that time, at least 30 minutes have passed, and then you can eat. If you don't take it that way, it is not absorbed as well, and it's not worth doing. Another bisphosphonate is zoledronic acid, or known as Reclassed. It is an IV. It's given by intravenous route. Sometimes it's given to people who can't tolerate the GI side effects of the oral bisphosphonates. Because it is given IV, it needs to be given in an infusion center. That sometimes involves a little bit more difficulty in getting that all arranged. But again, it is only once a year. And it can give certain side effects like some flu-like symptoms. And occasionally it can cause a decreased white blood cell count. So these are things to be aware of if you do take this medication. Another popular one is Prolia, also known as denosumab. It is an antibody. It's an antibody that works on bone resorption to slow it down. It's given subcutaneously every 6 months. So a subcutaneous shot can be given in your primary care doctor's office. It's usually quite well tolerated. I personally do use quite a bit of Prolia, particularly in much older people with osteoporosis, because the bisphosphonates are not always tolerated. Evenity is a new one called ramosumab. It's a monthly injection. I have to confess I'm unfamiliar with it and have not used it as of yet. Side effects of bisphosphonates, as I mentioned to you, at least the oral bisphosphonates, the GI side effects are probably the most pronounced. Reflux symptoms, that is gastroesophageal reflux disease, or GERD, or erosive esophagitis, can cause significant discomfort. Sometimes it can cause chest pain. And if these things happen, particularly erosive esophagitis, usually the medication needs to be changed from, excuse me, from a bisphosphonate to another type of medication. The bisphosphonates also have a small risk of something called osteonecrosis of the jaw. If you are expecting to have some dental surgery, oral surgery in the near future, you may want to either stop that medication or not start it until that is completed, to not have a problem like this osteonecrosis. With bisphosphonates, it was found that they linger in bones for a long time, and it has become popular to give patients a drug holiday. So in other words, a certain time that you no longer take it, but you still need to check your bone density scans to make sure it is not going down significantly. If bone density scan is either staying at the same level of a T-score or actually improving, then you should probably keep up that medication. If it is worsening, you and your doctor may want to consider changing to a different medication for osteoporosis. And side effects for denosumab or Prolia, injection site irritation, you may get some muscle or bone pain, but as I say, in my experience, it's been very well tolerated. For milder cases of osteoporosis, or for people who are osteopenic but close to osteoporosis, there's Evista or raloxifene. It's a selective estrogen receptor modulator, is what SERM stands for. And what it means is it has certain qualities that are estrogen-like and other qualities that are anti-estrogen-like. Estrogen-like because it helps build bones. It is anti-estrogen in that it helps decrease breast cancer, which is a good thing. And it's a well-tolerated pill. It's once a day. It can cause hot flashes. It can also cause an increased risk of DVT or deep venous thrombosis, which hormones can also do, estrogen. And lastly, I just want to comment about estrogen. Estrogen used to be used to prevent osteoporosis. In fact, way back when I started practicing, every woman, when she reached menopause, went on estrogen pills like Premarin or Prempro. This is no longer recommended. There was a large study done, the Women's Health Initiative, that showed that in postmenopausal women, the risk of heart disease taking estrogen or hormones outweighed the benefit of it helping or preventing or treating osteoporosis. So it is no longer used as a treatment. And lastly, there are medications for the most severe cases of osteoporosis. These are medications that are injected daily, and they are both derivatives of parathyroid hormone, which are both shown to build bone. Forteo has been around for quite a while, also known as teriparatide. It has a limit. You can only use it for 2 years, and usually after the 2 years are up, you are oftenly changed to a different, maybe back to a bisphosphonate if you can tolerate it, or some other medication for osteoporosis. Tymlos, abaloparatide, I have to admit also, these are not medications that I have used, also daily injection. And both of them have a small risk of possibly causing osteosarcoma. You know, with every drug, there's a lot of good stuff, but there can always be something bad, usually low amount, but it happens. That's the end of my part of this discussion. I would like to pass the speaker to Janice Pesco, who's going to talk more about exercise. Thank you.
Hi, everyone. I have to give you a little piece of information that's probably going to happen while we're talking. I just moved to this office, and I've discovered that the lights turn out automatically every 30 minutes. I just realized that as I got on the video today. So at some point, I'll go black, and I'll have to stand up for a moment and turn my lights back on. So just in case anybody feels like things are going a little crazy, you're probably right. All right. So I will be repeating some of the things that Dr. Siegel-Robles has already brought up, which I'm glad to do because it takes a while for us to really let certain things sink in. So, and I'll be trying to give you some additional information, a lot of information, hopefully, on exercise. Okay, let me bring up my slides here. Okay. So I just want to start with some objectives for us today. What I'm hoping to do is to have you leave understanding a little bit more about the latest research on exercise for osteoporosis, to understand your individual needs and how to exercise safely. There is no one size fits all for this. And to see how you can start or improve your exercise habit. Before we go too much further, I just want to ask you a few questions so that I can know who's out there. Who are all of you? So if you know how to chat, you'll see there's that little chat box. I can see a bunch of you have chatted already. If you just click on that little chat box, you can type a word. And I'm just going to ask if you would type in there for me, are you pre? You can just put pre, or post-menopausal, or are you male? So that we'll have some idea who's in the audience. And it will be, you can send that just to me if you choose, if you'd like to be anonymous. And I'm going to just check out all the answers I'm getting so far. Okay, we have a number of postmenopausal women, and we have some males in the audience as well. Very good. I can see for the most part, our audience is postmenopausal. I'm sure there may be some pre's that I haven't caught yet, but so you know who's here with you. All right, and now let's switch to another one. Do you have osteoporosis now? You can say no, or you can say osteopenia, or whatever you choose. I want to make it easy for you, just whatever you'd like to type in there. Okay, some osteoporosis, some osteopenia, a lot of osteopenia. Very good. Glad you're here now. Excellent. Okay, good, good, good. A lot of osteopenia and definitely osteoporosis as well. Okay, last question. What type of exercise do you do most frequently now? And the answer could be none. For many of us, that's the truth. So let's see. Walking, 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 walking. Very good. Swimming, biking, walking, but not now. Cleaning. I love that one. It takes a lot of energy. Okay, walking and biking, yoga. Very good. Trying to walk at home. Very good. Good, good, good. Okay. Gotcha. Some the activities of daily life, like gardening, taking care of your home, etc. Okay. All right, good. Thank you. So I can see a lot of you are typically walkers, and that's good. A great start, especially with what Dr. Siegel-Robles was just sharing with us. Okay. I want to look at, now why does that happen? Hold on. Oh, there you go. Exercise for osteoporosis. I want to look at some important factors, and I'm going to ask that you read this slide along with me and try to determine the areas that you fall into in these 5 categories. So are you at a previous fracture risk? A fracture risk. Have you had previous fractures? Do you know your Dexa scores? And all those items that Dr. Siegel-Robles brought up, you happen to be of a thin build? Do you have a family history? How is your diet? Do you take in calcium? Do you have a cancer risk, or any kind of a bone density problems that might be from cancer treatment? So those all put you at a high fracture risk. You might be at a fall risk, which is a different thing. Do you have some weaknesses? Do you notice that you may tip over from time to time? I know I find that about myself as I'm aging. Do you have balance or posture problems? Are you on many medications, polypharmacy? Do you have any sensation losses? Some people have, for example, sensation loss in their feet, neuropathies, vision impairments. If you're of advanced age, the age process itself will create some weaknesses. Then, do you use unsafe footwear, like my 89-year-old mother, who just is determined that she has to wear a really cool looking sling back shoe at 89, and I have to keep asking her to change her shoes? Do you have unsafe environments around you? As Dr. Siegel-Robles mentioned, rugs that are not secured, a lot of maybe uneven surfaces and other issues that make it unsafe, tripping hazards, etc. And are you on do you have other medical issues that might affect your safety? Cardiovascular problems, pulmonary problems, rheumatoid arthritis, osteoarthritis, diabetes. These are things that make exercise more complicated for you in some ways. So just important for you to be aware of. And we'll need to create programs that are designed especially for you. Your current fitness and exercise level is something we always have to take into account when you build an exercise program. What's right for you? A lot of people tend to just go out there and start exercising at the top of their capability, and that's not healthy and not safe. Are you premenopausal or postmenopausal? So I'm just asking you to keep note of that, and we'll come back to it a bit. So if you have one or more of those factors that we just mentioned, it is important to use caution. Exercise itself is a full risk at times for some people if you don't take precautions. So, but of course it's important to exercise, but you do have to be careful. And some of you do know that maybe your balance is not quite where you'd like it to be. It is very fixable. Many balance problems can be improved greatly, and it doesn't take long. You just have to put that energy to it. And I do advise that you seek professional help to design a good program for you because of all these factors and some of the new literature that makes exercising a little more complicated than we originally thought. Not undoable, but not just going out and doing the walking is the good part and the more easy part, but there are other exercises that are a little more difficult to do on your own and to progress yourself and to do all those things that'll make them the most effective. So what are the goals of the exercise? You do want to increase your bone mineral density, or at least slow it or maintain it. But the other very important thing is to decrease the risk of falling. That is as important, in my view, as it is to increase your bone mineral density. If you're not falling, then you won't be fracturing, most likely. Because as we've said, falling is the biggest cause of fracture. And what research is showing is that managing osteoporosis means combining all of these elements. So one more time, well, actually, I'm going to skip this one because I think the next slide is a little more easy to talk about. Here are the bone drugs here. Can you guys see my cursor circling around here? The bone drugs are allowing you to build your bone density and improve your bone geometry. Now, exercise can also do those things, not as effectively, but they can help. But what exercise also does is all of these light blue, purpley items here in these bubbles. So these are the things that exercise can help with, and all of these things will help to decrease your fall risk. And that's the place that we're heading, to try to decrease your fall risk, strengthen you up, balance, and give you really so much more protection against fractures with osteoporosis. Down here are some of those factors we said that make things a little bit harder, those clear bubbles. So those are some of the things we have to do to take into account your individual needs. Okay, we've said some of these things to exercise safely, build up gradually, no spinal twisting, excessive bending, abdominal curls. I want to mention that because people love to do sit-ups, and I haven't done a sit-up in 25 years or more. As a physical therapist, I exercise, but I do not do sit-ups. I think they're terrible for my spine and for everything else. It's just not a normal position to be in. I know a lot of sports people do them, but I don't recommend them. Or vertebral compression. I'm going to show a couple of examples of what vertebral compression might be. Okay, so we are going to talk a little bit about what research has found up until now. So I want to just point out there are two guidelines I listed here in number 1 and number 2. These guidelines, what they do is they take enormous amounts of literature and distill them into what does all that literature, when it's all combined, what does it say? And oftentimes the literature it can't prove certain things that we would like it to prove, but we have to take into account what we do know and use that to the best of our ability. So that's what we're trying to explain to you here, some of the things that have been found in the current research. And this is regarding building bone in particular in the next couple of slides. So if you are postmenopausal, this is what the literature is showing right now. This is what we know is proven. It doesn't mean it's the only thing that you can do, but this is what we know. We have some fairly good confidence at a moderate level, it's called, for these kinds of activities. So believe it or not, if you're postmenopausal and you stand on one leg, called static weight bearing, for 1 minute each leg, 3 times a day, that can improve your hip bone density. amazingly, I did not know this was true until this recent literature came out. Let me go back once again. These are from April 2022 and January of 2021. So this is really pretty current information, which is good. So this is so single leg standing, we're back to that slide again. Postmenopausal, again, walking, Tai Chi, these are called dynamic because you're on your feet and you're moving, but they're low force. So if you can do those 50 to 60 minutes 3 times a week, that's going to slow the spine bone mineral density. Now, this is a little bit more complex. Seated strength training, that's it, you're not weight bearing. So this is high force, meaning a lot of weight, or you build up to a lot of weight when you're not bearing your weight. So 1 to 3 sets of these types of exercises. And we have to talk about what are these exercises. I can give you some samples, but I can't just define them for you because they're going to be individualized for you based on your capability. So 1 to 3 sets of these 2 to 3 times a week. And that has to be done at 70 to 80% of your, what's called your 1 repetition maximum. So in therapy, we can do some tests either with 1 repetition or 10 and find out what's the absolute maximum that you can lift. From there, we have to dial it back to 70 to 80% of your maximum to give you that as your exercise routine. So those are some of the things that some of the analysis that has to happen to give you a good program. And that would have a modest impact on both your hip and your spine. Now, here's what the research shows that's super important. The combination of 2 of these above exercises is what really has the biggest impact. So the walking or Tai Chi and the strengthening exercises. And that has a modest impact on the hip and the spine, but also shows a substantial reduction in the risk of fracture, which is really a big piece of what we're targeting. So that's postmenopausal. I don't think there are too many premenopausal women in the audience, but this is these 2, the second and third rows here are the same as what we just said, except if you're premenopausal, you only have to be at 60% of your 1 repetition max instead of 70 to 80. But up above here, the jumping, the jogging, dancing, these are high force weight bearing activities rather than walking or Tai Chi, which are low force, right? These can be done premenopausally, jumping, high impact aerobics, et cetera, as defined here. So I know this is not something you can remember easily from here. And as Marsha said, you can get these slides for yourself after this. If you'd like to put your email into the chat box, Marsha can send these to you after the lecture. Okay, I'm just going to give you a couple of minor exercises. I'm going to whip through these because I don't want to offer you a specific program for you, but these are slightly they're lower levels, so they're not too dangerous. So this is trunk extension. This is for your vertebral bones, right? Trunk extension, and even this woman here in the blue shirt is a little arched there in the low back. You don't even have to come up anywhere near that high, but just arching your back and getting that trunk extension is excellent. This is also trunk extension on the right side in this hands and knees position. But I've heard people tell me that this hands and knees position can be a little dangerous and people fall over because it's hard to balance on when you lift 1 arm and 1 leg. It's hard to balance on the other 2 limbs. So you have to even be careful about that. The abdominals, which then do some trunk flexion exercises. So now you're strengthening your trunk and your vertebral column again. Simple exercises like 1 leg lifting, 1 at a time. But you see you're in a nice safe position and you're not doing a sit-up here. You're using your legs as the lever instead of your head. And then on the right side is a little harder, lifting 1 leg at a time. You see her leg that's not bent is off the ground a bit. I'd like you to put that back down on the ground. So 1 leg at a time coming up, much easier on your back and on your body as a whole. So these are just some simple things to start with. A couple of others for hip extension and your gluteal muscles, which are targeted a lot for that hip, for improving your hip density. So this is called a bridge, a very simple exercise. And again, she's in the extreme motion. You don't have to come up as high as humanly possible, but these are the kinds of exercises that can help a little bit. These are simple. You can do them when you wake up in the morning in bed. I sometimes do that. And then on the right side are stepping. It's similar musculature that you're using, and you're just stepping up and stepping down. But very important, there's a railing here so that you're not putting yourself at risk of falling here. Okay, really important. But what's important is that you don't grab that bar. You keep your hand on it, you touch it so that you can grab it if you were to lose your balance, but you don't want to lean on it because then your leg muscles aren't getting the work that they need to get. Okay, a little bit more. So now I want to talk about those seated strength exercises. We're going back to that slide with all those high force exercises that are recommended. This is just a sample of what some of the studies have shown and what some of the studies have used to do the high force seated strengthening exercises. Some of these require machinery, some of the equipment that you'd find in a gym or in a physical therapy practice. They don't have to be done this way, and a therapist would be able to work with you to figure out how you design a program, maybe in 2-3 weeks, and then be able to do that program on your own and maybe come back for some check-ins to see if it's time to maybe progress or just check in on your form and how things are going. So that's one way to go about building a program. Okay, here are some other types of exercise that people often ask about. These are great exercises, yoga and Pilates. Electromagnetic field pulse therapy, if you've never heard of it, it's okay because it's not effective at building bone. The vibration platform is very hard to come by, but sometimes people use that. You exercise on a vibrating platform. It has some benefit, not for postmenopausal, but for pre. But none of these exercises really build bone on their own. So this is not these are not bone building exercises. They are valuable, but just know that those are not going to build your bone as far as the literature can show right now. We'll see what happens in the coming years as more studies are done. Okay, talking a little bit about spinal compression. I want to talk about these extreme positions. I love yoga, I do yoga, but there are many positions in yoga that are just too extreme, and especially for osteoporotic bone. So if you look at these, how many are there? 7. Look at these 7 poses. You can see that they are pretty extreme looking, right? I mean, you probably haven't done a single one of these, unless you do yoga. You haven't done a single one of these kinds of positions just randomly in your life, right? They're unusual positions to be in. So that's a way of knowing that it might be too extreme, is that this is not a position, this is not a natural pose that I might be in on a regular basis. So that's a good way to know that it's probably too much. Here are some that are less extreme. They're all yoga poses, but they're not in those super extreme ranges. Some of them are hard, like I is very hard, but a lot of them are hard, but they're more safe and on your bones. Some of them do require a lot of balance. So if you're going to go into a single-legged position, you should probably be by that. Often a studio might have a balance bar on the side, a ballet bar. You might want to stay near that ballet bar to do some of these poses so that you're always protected if you know that your balance is not sufficient. Osteoporosis in men. All the things we've said about exercise are helpful to men as well, especially to improve your balance and your strength. However, the research is not showing right now what helps men the most to improve that bone mineral density. It's not showing up yet. In time, we'll have to keep revisiting it, but right now we don't have enough evidence to know what's the most helpful. But doing all those other things to improve your balance, strengthening up, fracture risk, improving your posture, all those things will help. All right, I'm not going to take too much time with this because we're already 2 minutes to 11 and I want to give some time for questions. But getting into a walking schedule, you can start with 5 minutes a day. That's all I'll say, okay? All there is to do is to just get started a little bit. It doesn't matter that you're not doing your 30 minutes. Whoops, there goes my light. Hold on. Okay, so gradually you'll add time. Okay, so I won't say anything more about that. I think you've gotten some information about that. Couple of things here. Don't forget when you're exercising, everyone forgets to breathe. Breathing actually improves your balance because you're not tensing up and your body's ready to catch yourself if something happens. Please remember that exercise includes breathing. Supportive shoes we've talked about, walking tall. All right, I'm going to ask you to do one thing. We've got a minute or two here. If you're sitting up in your chair now, if you can sit in a pretty decent posture, kind of symmetrical with your feet on the ground. I want to talk about being tall. This third bullet says walking tall, but let's sit tall instead right now. And I want you to imagine that you're growing taller just a little bit, like maybe it's a half an inch, maybe an inch. And it's as if the sky is pulling you up from your crown, right? So here's me in my regular posture, and here's me when I do that. It's very relaxed. I'm not pushing, I'm not straining, I'm not throwing my shoulders back. I'm just naturally lifting. And there's something about doing that will improve your posture more than all of the things that we think about, like tightening your abdominals, move your shoulders back, push your head back. None of those things. All there is to do is to just pull yourself up as if the sky is pulling you from your crown. And that will do a lot of things to improve your posture naturally. So you can do that when you walk. You can do that when you exercise. Letting your arms swing. I just have to mention this. Your arms are like the pole that a tightrope walker uses. So if you don't let your arms swing when you're walking, if you tend to grab hold of your purse or carry packages or put one arm in your pocket or put your hands in your pockets, it's really, really not helpful. If your arms are available to swing, you might be able to catch yourself when you tip over. If your hands are in your pockets, probably not. Okay, so just a quick some next steps, some things to hopefully that'll put a little inspiration into your routine. Make a commitment to bump up your program after today. That's our recommendation. There's a book called Tiny Habits that I think is really nice, talking about how to make tiny little changes and make a new habit, but a little bit at a time, so it's not that horrible feeling of, oh my God, I can't do this. Okay, very important points to take away: combining your weight-bearing exercises with a strengthening program, always including balance. And for help, the people that are the most, I think, beneficial to help would be people who are certified specialists. So they're called certified orthopedic therapists or certified geriatric therapists, or a designed osteoporosis therapy program. There are some, they're few and far between, but there are some around. Lastly, after saying all that and telling you that we have to do all the right exercises, your exercise actually has to happen for it to be effective, right? So if you're not exercising, the most important exercises that you can do, according to Susan Ott from the University of Washington, she's a physician, the most important exercises are the ones that you will continue to do for the rest of your life. So make sure that you're doing things, as Dr. Siegel-Robles said, things that are fun, things that you can enjoy. Thank you. The rest of my slides are just references, which you also can have available in the slides when Marcia sends them to you. Say thank you very much.
So thank you very much, Dr. Siegel-Robles and Janice Pesco. It was a wonderful presentation. We will be taking questions shortly. I just wanted to remind everybody that I put the evaluation survey in the chat box. If you can kindly complete that before you leave, that would be great. I will linger around for a little bit, so you'll have a chance to fill those out. And again, we really appreciate that. Also, we have the recording link is posted, and I did jot down all the email addresses of people that wanted the slides, and I also did put my email address in there, so you can note that as well for requests for the slides. And I guess we'll get started with questions. So speakers, do you want to, would you like me to read them off, or would you like to?
I can handle a couple that I see now, and then if there are others, Marcia, that you can see, that would be helpful.
Okay, so maybe we can go from the top of the list that you see. Is that okay?
Okay.
And I can keep track.
Okay, well, I saw one question about swimming, and then also using a cane and doing plank exercises. So swimming is a little bit complicated. I just saw some research recently about water activities. They do not build bone as far as we know. That doesn't mean they're not useful. They're certainly good for strengthening and everything else. There's just one thing that I did see something about, that there's something about water that could actually be detrimental. And I actually would, if you'd like to, for me to get back to you on that, I do have to look it up. I did not realize that until this talk. So I'd have to find out for you. As for walking with a cane and swinging your arms, you're right, it's hard. But what's interesting about a cane is you bring the cane forward with the opposite leg, and that's just what your arm would do if it were swinging. It's there to help you. It goes forward with your opposite leg, and it acts as if your arm is swinging in a way. But your other arm can still do a little bit as long as it's free to respond, free to react. If you were to tip, that arm is there to kind of, it throws your weight and it helps you come back to your center. So that's how I would ask you to manage with the cane. As for plank exercises, I'm not sure what that question was, so I might have to ask you if you picked that one up, Marcia.
Okay, plank, let's see what I have here. Sorry, there are a lot, so I'm just scrolling through. Are planks beneficial for osteoporosis?
I'm going to say yes. Yes, in multiple ways. It actually counts as a strengthening exercise. So it's part of the strengthening program, as well as good for your balance. So yes.
Thank you.
You can do them. That doesn't mean everybody should do them, though. Only if it's something that you've been doing, it's something that you know that you have the strength for and part of your program. Excellent. Otherwise, you might have to build up to that, get some help.
I'm happy to read through a few. I know there were some about drugs. Are there any drugs that build bone besides Evenity? I think that was sort of answered, but doctor, you can answer that. This drug is a boxed warning for cardiac events and strokes and isn't covered by my insurance.
Yeah, that's a really good question. And there's something that I really didn't talk about in the in my talk, but a lot of the research indicates that bone density in and of itself is not necessarily the whole answer about what's going on in your bone. It's just one way that we have found to measure the strength of the bone. But sometimes a lot of the medications can show a decrease in fracture rate, even though they don't see a significant difference with the T-score on a bone density scan. So that makes things a little bit hard to answer. Some of these medications are, they do say that they build bone. It's kind of hard to quantify though. And honestly, when it comes to, as a physician, as long as the patient is tolerating the medication that they're currently on and their bone density scan is not going down, I tend to just keep up the same medication until a drug holiday, if it's a bisphosphonate, is needed. So I don't know if I can really answer that question. I know the newer meds do purport to build bone, but again, there's a lot of questions about that. I mean, if you look at a bone density scan also, I don't know if you've ever had, any of you have had this happen, but you get a bone density scan, in 2 years you get the next bone density scan, and in one area, your bone density got better. In the other area, in another area, it got worse. Now, your body is doing basically the same thing. It's hard to explain why that happens or how that happens and what to do if that does happen. So there are still questions out there, and I don't know if I can really answer you exactly about building bone and how much bone is built, per se.
Please discuss regression when Prolia treatment is ended. I'm sorry, regression. Please discuss regression when Prolia treatment is ended.
I know that has been mentioned, and honestly, I have to admit my my ignorance about exactly how much Prolia, how much regression there is after Prolia. I understand that can happen, and I would assume that if Prolia is stopped for some reason and you have significant osteoporosis, you should be going on to some other medication so that you wouldn't have the regression. But I really, again, that's kind of out of my scope of expertise.
How soon should I take the bone density scan after Reclassed injection?
So again, that Reclassed injection is done once a year. And most of the time, these bone density scans are usually done every 2 years. It all depends. Sometimes some physicians like to check it after 1 year to make sure that they've made a difference. Particularly the specialists like rheumatologists tend to sometimes do that. There's also people can do things like bone markers as well, but it's not the common, it's not the in standard use either. So I would say, as a rough estimate, get it every 2 years. If your physician feels differently and wants to do it more often, get it more often.
Okay, just going.
But I would not get it like, a month after you had the injection. That's just not enough time for it to do anything.
I think
Marcia, I saw one while you're looking about Capital Health and having an osteoporosis therapy program. Yes, we do have therapists who are well-informed and able to design programs that would benefit you as an individual.
if someone has breast cancer treatment, chemo, radiation, surgery, eventual hormone TX for 10 years.
Treatment.
Yeah.
Treatment, okay. Can she avoid osteoporosis through
Medications.
diet and exercise rather than drugs?
I'm sure that her doctor will, suggest she can try that. And it's important to closely follow bone density probably while she's doing that. I do know that most of the docs, if there's even like a little bit of osteopenia and a patient is on one of those aromatase inhibitors like anastrozole, letrozole, meds like that, exemestane, they do tend to push the meds for osteoporosis significantly. I encourage everyone to do the diet and the exercise. That's going to be helpful in any and every situation. So you do that anyway, and hear what your doctor has to say about, hear what your oncologist has to say about, should you take it, shouldn't you take it, should you wait a while? Yeah.
Why do biphosphonates pose risk of femur fracture when they are supposed to build bone?
That's a good question. I don't know that answer. And I think that is the case after you've been on it for a certain amount of time, but I honestly don't know that answer.
Okay, supplement questions. Vitamin K2, what is the maximum for vitamin D? What is considered a full glass of water? How many ounces? Do trigger point injections, steroids in hip, are they bad for osteoporosis? So we could start with
That's
vitamin
like
K.
four questions in one. The vitamin K for osteoporosis, I'm not aware of a dosage that's acceptable for vitamin K. For vitamin D, like I said, you can start with 800 to 1,000 international units, but I like to rely on getting vitamin D levels. For my patients who I do physicals on once a year, I always include a vitamin D level, and I see where they are. And a lot of times they're on a certain amount of supplement, maybe it's 1,000 units a day, and they're still low. I'll tell them to take 2,000. So I kind of changed the amount that people are taking depending on what that level is. So KD, a full glass of water, I consider a full glass of water is 8 ounces. And what was the last one about? Oh, injections, corticoid injections in your hip. It all depends on what the injection is being done for. I mean, if you have a terrible trochanteric bursitis and nothing is working pain-wise and steroids help it, then it's the thing to get. Usually the doctors won't do them any more than about every 6 months or less often. But steroids over time, particularly chronically over time, do tend to decrease bone strength. And that's probably why the physicians do not give it any more often than every 6 months. Yeah.
There's a sunscreen question. Does walking outside without sunscreen for 30 minutes, is that okay if you don't have skin cancer in New Jersey?
Yeah, that's one of these things, I'm a pretty firm believer in using sunscreen because there's a lot of skin cancer out there, lots and lots. Granted, we're not like a really, really sunny state, but we're sunny enough here. So I would err on the side of using a little bit of sunscreen and walking. If you chose to limit the time you're in the sun, you might be able to do that. But nobody has really figured out a way to find out how much sun exposure is enough. Is it all at one time? Is it most of the common thought is that it's cumulative over years. So for me to try and tell you 30 minutes is okay, but 60 may not, I can't say that. I tend to err on the side of using sunscreen because I just see too many skin cancers, particularly in light-skinned people.
I think we may have answered this. How soon should I take a Dexa scan after a reclass shot? maybe it was a
I
different
think we
drug.
did answer that. Again, it's anywhere between 1 year and 2 years is what I would say. It really will depend on the doctor who's giving the reclass and how they feel about it. I would not take it any sooner than 1 year from the reclass injection.
I'm 55 today, so I'm young and I'm old. I have MS, osteo, I guess it's osteoporosis. It just says osteo. I use a cane, walker, scooter, can still drive. Where do I start to keep moving as far as PT?
Yeah, I would think that, the PT part you can answer, Janice, but I think that water exercises, and there's a lot of places where they have chairs to help you in and out of the water, is a great exercise. What you're doing is you're pushing against the resistance of water. So you can build some muscles as much as you can tolerate it. And you're also not quite weight bearing because the water is bullying you up. So, but it's really enough to get a good workout. Just walking, from one side of the pool to another, or, walking in a small circle, or whatever you feel you can tolerate. Just again, the same things. Start slow. Start a little bit at a time and slowly build it up. But I'm sure your doctors have also told you, the more you do try to, use your muscles, the better they'll work for you. And conversely, particularly things like arthritis, the more people say, oh, my hip hurts today, I think I'm not going to walk. That's not a good idea. I mean, I'm not going to tell you to go walk when it really is painful, but if it's just a little bothersome, a lot of times arthritis gets better with movement. Our bones, if we don't move, they get stiff and they don't move, they don't bend or extend well, your joints. So if you move, that should get better in some way.
Agreed, 100%. And as far as the water piece goes, maybe I shouldn't have mentioned it because I don't have the data. So if you're doing water exercises, I would not say stop. Don't stop swimming. Don't stop doing water aerobics and those things that are available in a pool. I just wanted to make sure that there's nothing in that literature that we should be concerned about. And there are 2 people who've asked me to get back to you. I'm happy to do so, but I wouldn't stop if it were me. I really wouldn't unless I knew there was something really significant. So I'll let you know.
I see a couple of questions on the bottom here about any of these meds predisposed to urinary tract infections. Not that I am aware of. And the other question is, should we have at least 1% milk instead of skim milk? Again, the milk factor there'll be the same amount of calcium in whole milk as there is in reduced fat milk, as there is in skim milk. The reduced fat is just to cut your fat intake. It doesn't really have to do with the, calcium in this sense with bone strength. It should be the same amount of calcium all across the board.
If you're on the cusp of osteoporosis at -2.5 and an avid exerciser, should you start on Fosamax?
It's a really good question. I guess there's a few things to consider. Is there family history? If you have a family history like I had with, compression fractures, hip fractures, all this stuff, I would say absolutely yes, definitely go on. If you've had a bone density scan 2 years ago and it was just about the same number as it is now, you might be able to temporize and wait and just keep up your regular exercise, maybe lose weight, things like that. Those all do seem to help. But again, if it made a big jump from 2 years ago to now, and it's now at 2.5, I would say that whatever you're doing is probably not quite enough, that medications will be indicated.
Can Dexalent decrease bone mass?
Dexalent is not for osteoporosis. Dexalent is for reflux, like GERD and reflux esophagitis, and I don't know that answer whether it decreases bone density or not. I think no, I'm not even sure. I'm not sure. That you should be able to Google that and find that out, but I do not know that answer.
Does sunscreen lower benefit of getting vitamin D?
Again, sunscreen is supposed to be blocking those UV rays that are needed to make the vitamin D in your skin. Again, like I said, it's a trade-off. Me personally, I would go for the sunscreen, especially if I'm going to be, if I'm going to be out for a short time, maybe 30 minutes or less, I might not, but any longer than that, I would definitely use the sunscreen.
Let's see, there was something else. Oh, coffee. Did you answer that? Coffee, is that not good for bone density?
Yeah, I don't know the answer to that either.
Okay.
People like me, I have I have osteopenia bordering on osteoporosis, but it's really hard for me to give up the coffee. So I continue to drink it. I try to limit it, but I do drink it. I confess.
Why are mature women expected to have bone density equal to the young women, or it requires drugs? Isn't it normal to have less bone density when you get older?
It's absolutely normal, but the thing is, the whole idea there is that they're trying to prevent the fractures. So like I said, on the bone density scan, there's a T-score and there's a Z-score. If you look at the Z-score, it'll tell you how your bone density measures up against other people of your age. And so you might even be doing slightly better than other people of your age, but it's still telling you that your bones are weaker and more prone. And when they're weaker, they're just more prone to fracture. And as time goes on, that more prone to fracture just increases over time. It's not like, we should, or like they're, prejudiced against us or anything like that. It's just the way bone density is. And that is the measure that we have at this time to decide osteoporosis medications, osteoporosis, no medications, things like that.
If you have a negative 3.2 score, can you just do exercise? What happens if you do not take medication?
Oh, that's pretty severe osteoporosis. I would say do all the exercise you want that's safe, like Janice and I have talked about, but I would definitely go on a medication for for negative 3.2. Because remember, all you need is one fall. People fall not when they're like paying attention to what they're doing, but like, sometimes they're just doing something and all of a sudden they're on the floor. Falls happen under the best of circumstances. The falls happen, and if a fall in a person who has negative 3.2 bone density can be devastating. A hip fracture will mean, a week in the hospital, probably 2 to 4 weeks in a rehab program. When you get home, you can't do stuff for yourself for quite a while. You can't go and shop for yourself. You can't drive. There's a lot of, problems that happen from that one fall. So I would not take the chances with a negative 3.2 score about not being on a medication.
Thank you. For some reason, my video will not turn back on, so.
I would also recommend that for people who have severe osteoporosis, I usually defer to rheumatologists at that point. They deal with much more osteoporosis than I do, to get their idea of what is your best choice for medication, et cetera.
Thank you.